much for the introduction. I'm going to be starting off the talk, and then Matt will be doing the lion's share. We titled the talk "TRALI Behind the Scenes," not only as a nod to award season, which we are currently in the middle of, but also to give you a little bit of insight about what happens when you report a TRALI. Can everyone hear sound quality is okay?
Yes, it's good.
Okay, great. So we'll go to the next slide. There's no relevant conflicts to disclose for this particular content. Our objectives today are, first of all, to review the clinical characteristics and investigations for TRALI through a case presentation. And we hope also that you will be able to understand the processes and implications at Canadian Blood Services when a suspected TRALI is reported by the hospital. This is a recent case that was submitted to TMRG, and I think it follows nicely after Christine's talk. It's de-identified as it comes to us, de-identified as well, but this is a case of a 21-year-old female who has sickle cell disease. She has a prior history of acute chest syndrome, or ACS, silent cerebral infarcts, and pulmonary embolism, and she has presented to hospital with a vaso-occlusive episode with concern for an underlying pneumonia, and they saw some new nodularity on a CT chest in the right upper lobe. On the 15th of the month, when this was reported, the patient developed increasing chest pain, a rise in troponin, ECG changes that were all consistent with presumptive diagnosis of ACS, and 3 units of red cells were requested for her hemoglobin of 46. This is a summary that's put together by from the information that you supply us and from additional back and forth that often occurs between the medical officer who's received the case, back and forth with the transfusion safety officer, if there is one at the site, and liaising with the clinical side, which may be in the form of medical director of the blood bank or with the clinical team as well. And so this is a summary that was put together for this case based on those conversations and documents and the information that is submitted on the forms that we receive. So 12 hours preceding the reaction, the patient had been maintained on 5 liters of oxygen for the preceding 48 hours. Between 8 and 10:30, the patient completes the first unit of 3. 11:30 to 1300, the patient completes her second unit of 3. And then at 14:55, pre-transfusion vitals are as seen on the slide, and she initiates her 3rd unit of the 3 red cells that had been ordered. At 18:20, there are reaction vitals documented where you can see that the blood pressure has gone up a little bit. The oxygen saturation is sitting at 98%, but the patient has gone from 5 liters to 100% FiO2. Her transfusion is stopped due to dyspnea. There are only 40 ml of the red cell left in the bag. The patient is now on 100% oxygen, as mentioned. Initial chest x-ray and clinical exam are consistent with volume overload, so she receives a total of 180 milligrams of Lasix and diuresis 2 liters. Her oxygen status doesn't really change, and the patient remains on 100% FiO2. She's intubated and transferred to the CCU. And this is a summary of investigations. Again, it's reflective of what we piece together based on the information that is provided from the clinical side. There is a pre-reaction CT from the same day of the reaction, which had been performed for increasing oxygen requirements. There was no pulmonary embolism seen. However, there was a comment on increased ground glass opacity with new mild nodularity in right upper lung that could be an infection, but ground glass can also be seen with edema. And then the post-reaction, there's a chest x-ray from the 16th of that month that showed cardiac enlargement, increased interstitial markings, which could represent volume overload or an infectious process. And then we also have here some information from the 17th, 18th, and 20th, where you can see a progression of bilateral lung opacities in the days that follow on imaging. In terms of cardiac, there was 1 month prior a BNP that had been done that was in normal range. 2 days after the reaction, the BNP was elevated. And there's an echo done from the day of the reaction where the LVEF is normal at 63% and LV and RV size are normal. There was also a comment that the absolute neutrophil count increased from 13.4 to 17.1 post-reaction. The course in hospital for this patient included the clinical team considering TRALI because the patient was still hypoxic after extensive diuresis. And as of the 21st of that particular month, the patient had remained intubated. So I'm going to hand things over now. We're going to come back to the case and we're going to get your votes. But now Dr. Yan, Matt is going to take this over and he's going to walk you through what you do and what we do at Canadian.
So thank you for inviting me to speak to you today. Although we are in a virtual format and I can't see face to face, I think one of the benefits is that I get to join you from the West Coast and otherwise I may not have been able to make it. So what I'm going to talk about is what happens when you report a TRALI to CBS. I know that sometimes it can seem a bit mysterious what happens behind the scenes and why we keep bothering you with emails for more information when you've already provided us your ATR report and your TISS form. So one of the first things is when you first suspect a TRALI, following your initial review by your lab, the number one thing you should do is report it to CBS. And you can do this by notifying your local distribution via fax of an initial report or a phone call. It really depends on what your hospital process is. But I think in these circumstances, a phone call is always nice. And in terms of what report you can give, really what we need is that you suspect a TRALI and then what are the implicated unit numbers. If you provide a bit more information in terms of your preliminary report, then that is more than appropriate. So what this does is that it triggers an immediate segregation and quarantine of any implicated in-date transfusional co-components. So when distribution gets this notice of a suspected TRALI, the medical officer on call gets a call and the case is quickly reviewed. And then what happens is that for TRALIs, we will segregate any in-date transfusional co-components from the past 12 months. So really, usually that is mostly what we're concerned about is if there's any non-expired plasma that still exists and or red cells, usually the platelets would have been expired by then. So once segregations of co-components have occurred, so that's really the function of that initial reporting to CBS. Then kind of everything else happens slowly in the background. We have some time before we have to kind of come to a conclusion and determine whether or not the case is reportable to Health Canada. So what distribution does with your information is they then forward it on to our national medical office for further management. That case then gets assigned to both a nurse and a physician within our team. And they will review that initial information once our initial quarantine and segregation has been performed. So at that point is when they may come back to you for more information as the case is evolving at your site. So what may happen then is they may reach out to you to see if you have submitted a TRALI patient data form, which we'll talk more about afterwards. So really the two pieces of information when you suspect a TRALI to submit after you initially notified CBS is really the clinical information. So this includes things like your vital signs, any chest x-ray reports, echoes, et cetera. And really what happens is in collaboration with our medical officer that's overseeing the case and with yourselves, we determine whether or not this case warrants submission to our TRALI medical review group, or otherwise known as TMRG. The other thing is patient samples. The patient samples really is for HLA typing if we need to do further investigation. And these samples are sent to the Platelet Immunology Reference Laboratory, which is in Winnipeg. These samples are stored and will only get activated after TMRG reviews a case and determines that donor investigation is necessary. In that situation, which we'll talk about, if donor investigation reveals a donor antibody, then these patient samples will get processed for HLA typing to determine if there's a cognate antigen present. So in terms of forms, what that means to you is for the clinical information, really the TRALI patient data form has been updated to try and capture all that information, some of which may not be on the TISS form, although as Joanne had said, we've been working together to try and collate those two. And this form should go to CBS distribution with your initial report if it's available, or if you happen to fill it out later, you can still go to distribution, but usually at that time, you'll probably be in contact with someone from a medical office that is reviewing the case. And then the patient samples should go with a patient platelet lab requisition to the platelet lab in Winnipeg, where these samples will be stored. I know previously there was confusion as to where samples and the TRALI patient data form should go. So I just want to reiterate, samples with the lab requisition go to Winnipeg, but the actual clinical information should go to your local distribution. Just a word of caution that if you were to send everything to Winnipeg, what would happen is that there would be a delay in notifying CBS of the TRALI, in which case we wouldn't be able to immediately intervene with any quarantine or segregation. And sometimes that does happen. To find these forms, it's on blood.ca under laboratory services and requisition and forms. And then I have a snapshot here of both the requisition for the patient samples and then the TRALI patient data form for clinical information. So recently in January, you would have noticed that the form was updated. And I want to thank many members of TISS Ontario that helped review this form to provide your perspective as someone that submits and fills this out. We condensed it to 3 pages. It's now electronic fillable. And then the other factor is we try to reflect newer literature that has been made available with regards to definitions of TRALI or how we view TRALI. So there's been more kind of patient history fields added in terms of ARDS risk factors. And then it's a bit more streamlined in terms of pre and post reaction and things that we're looking for in terms of cardiac findings, volume status, and then with the TRALI type 2, your respiratory status within 12 hours pre-transfusion. And then this would be the last page in terms of any implicated products. And then again, some instruction here that the sample should go to Winnipeg. So when it's been determined that the case should go to TMRG, TMRG will then review the case. So the role of TMRG is to determine really if donor investigation is required. TMRG will advise on donor actions and donor investigation if we need to do deferrals, but we do not advise the hospital on what you should call the reaction. So if you called it a TRALI at the hospital level, then that's what it should be. It's TRALI is a clinical diagnosis. Really what we then provide you is whether or not we move forward with donor investigation or not. In terms of who's on TMRG, there are 6 CBS physicians, 3 hematologists and 3 hematopathologists, and our trainees usually do join as well. So TMRG meets on a monthly basis if there are cases for review. Usually we have anywhere between 2 to 5 cases to review, and the members will receive a 1-page summary of the case, which is distilled from the information that you've provided. I will note that since the new updated TRALI form has come out, I've noticed there's been a lot less back and forth between the hospitals and us in terms of trying to get more information. And really that was one of the goals of updating the form. The 1-page summary that the members receive does not include any donor information. So we don't want to bias the members. If a donor is a prolific donor with over 500 donations, we don't want them to choose a categorization that may not defer them just because they want to keep the donor. The members then submit individual votes to the chair, and then we collate the votes, and then we meet virtually once a month to discuss the voting and reach a consensus. We have always reached a consensus with every case that we have seen. And then really what happens after that is based on the voting category, determine if donor action or investigation is required. And then we send a closing letter back to the hospital. So in terms of voting, here are the 6 categories that they can vote with. We have TRALI, possible TRALI, and TRALI inconclusive. TRALI inconclusive means if there is some missing information, either clinically or from an investigation, where we can't rule out a TRALI has occurred. A most common one that we see is if a potential TRALI happens in the community, but given the timing and resources that are available in the community, immediate chest x-ray may not be available, then we may decide to call that a TRALI inconclusive because we're missing some of the criteria that's necessary to make a definite or possible TRALI designation. So if the membership votes on one of these 3, what happens is the donors will be placed on surveillance, they will be deferred, and they will be forwarded for donor testing. The other categories include TACO, TAD, or other. And if these are voted upon, what that happens is that surveillance is placed on the donor, but no deferral or donor testing is performed. And we've been slowly incorporating the new consensus TRALI definitions when making these decisions. So if we at TMRG decide to move forward with donor testing, what happens then is that we collect the implicated donor samples and we run HLA antibody testing on the donor sample. If the HLA antibody test is positive, then we will then open up the patient samples you sent us and type the patient for cognate antigens. Regardless of that result on the patient, the donor is indefinitely deferred. If the HLA antibody test is negative, the donor, depending on where they are located, may be able to donate source plasma only. At this time, we currently do not test for HNA, mostly just due to the limited number of cases we see and that the impact on donor management would be quite limited at this time. However, there is a Health Canada approved HNA kit, and it is something we are investigating to see if we can incorporate into our platelet lab to further enhance our TRALI investigations. So following that, a closing letter will be sent out, and the type of letter depends on TMRG's decision. If there's no donor investigation, you'll get a final conclusion letter. However, if there is donor investigation, you'll get an interim letter telling you that we're going to do donor investigation, and you'll either get a final letter with the HLA antibody results, and it'll tell you if they're cognate or not, or you'll get a final letter telling you that the donor never returned. And we usually send this after 1 year from the case initiation. So this is what the letters look like if you've ever submitted it. And again, really we highlight that TRALI is a clinical diagnosis and that our decision may sometimes differ than the decision from the reporting hospital. And therefore we're not trying to overturn your decision. Really, our job is for donor investigation. So in terms of the last 2 years, in 2019, we reviewed 17 cases at TMRG. 3 cases were referred for donor investigation. Of all 3 cases, donors returned, some as late as last month. And then 1 out of the 3 cases had patient-specific HLA antibodies identified. Last year, we reviewed 23 cases. 3 were referred for donor investigation, and currently we're still waiting on the donor samples. Most of these cases were reviewed in November and December, which is why we haven't been able to process the donor samples yet. So with that, I'm just going to pass this back to Nikki. This is kind of the one-page summary sheet that our members get before they make their decision.
So just to remind you about the case, this was a 21-year-old woman with sickle cell disease who had been admitted with probable acute chest syndrome, and she received 3 units of transfusion and then had an increase in her FiO2 and eventually was intubated and transferred to the ICU. And then as a reminder, post-reaction showed cardiac enlargement, increased interstitial markings, which could represent volume overload or an infectious process. And she also diuresed 2 liters of fluid. So we'll move to the next slide. And I'm going to get you to all imagine that you sit on TMRG and you just reviewed that 1-pager. And I want you to tell us how you would vote on this particular case? And you can pick more than one answer. Sometimes we pick more than one answer if there's more than one thing that might fit. Okay, so this is very interesting. We have 54% who said possible TRALI, a bunch of people who said TRALI inconclusive. There is some TACO, some TAD, some other, some TRALI. So you will be very interested to see how we ended up voting, which is on our next slide. So we had 10 individuals at that particular meeting, the 6 TMRG voting members and 4 trainees who discussed the case and voted. And again, we are voting in isolation from each other and then submitting each of us our votes. And then Matt sees them all and puts them together. And the unanimous decision was made not to defer or test this donor. So members of TMRG did not find this case to be consistent with TRALI because of a number of reasons. So if you recall, the timing didn't quite fit within that 6-hour block. The diagnostic imaging of the post also didn't show the bilateral infiltrates that we would, diffuse infiltrates or opacities that we might expect. And then also given the patient's comorbid and underlying conditions, her acute chest syndrome, and pre-existing hypoxia, although it was much more mild. So, you know, I think people felt, you know, this could have been a component of TACO, this could have been other, some combination. And we issued a letter to the clinical side in order to summarize the TMRG decision. But again, if the clinical side said and favored TRALI, we are not looking to impact the decision made by the clinical side, but we are communicating to the clinical side that we will not be deferring this donor, and we will not be sending this donor's samples for further testing.
So just to follow up with Nikki's decision slide, the one thing we do is we do place surveillance on these donors. So if they were implicated in another reaction, we would know at that point. So just to close, I just quickly want to talk about future directions on where we're headed with TRALI. And I want to thank Joanne for all the work that she's done with TISS Ontario and being so open in collaboration and trying to reduce the amount of work that you guys do and the amount of reporting. And myself working at the hospital, I do know there's a lot of duplication. And I think the ideal system would eliminate that and would also, based on whatever you choose on TISS, would automatically do the reporting for you. So at this point, we're not there yet, but I think we can dream big and hope to move in that direction. So I have been working and discussing with Joanne. She did mention about putting the TRALI patient form into your electronic TISS report so that you don't have to submit it twice. And right now we're just in discussions of what is the most appropriate way for you to submit that information. Because there are, again, as I said, 2 functions. One is the immediate reporting to CBS so that we act on the co-components. And then the other one is kind of when you have all your investigations together to provide that to our medical office so that we can decide with you whether or not it can go to TMRG or not. So we're not there yet, but hopefully within the next couple of months or so, it'll become clear what the best direction will be, and perhaps we may pilot it before we move, hopefully, to a more connected system. So to close our talk, just some key messages. The first one, I think you've heard many times. If you suspect TRALI following your evaluation of transfusion reaction, let us know, call CBS distribution so that we can act on those co-components immediately and defer the donors, especially if they're plasma donors that come in every week, we need to take action. And then after that, you can submit your completed TRALI patient data form that will help both the medical officer looking after the case and TMRG in making appropriate decisions regarding donor investigations and deferrals. And then as Nikki and I had said, our decisions are really about the donor. They're not meant to impact your final categorization at the hospital. So with that, I'd like to thank you for your participation and your attention and welcome any questions.